up. But the Buzz is a communications workshop, and this particular one is slated for healthcare providers, but I think you'll find that this is going to work for you in every relationship that you have. So let's keep that in mind as we go through it. As healthcare providers, you need to take home some messages, but just as people, we need to take home some messages. Okay? So we're going to try to accomplish a few things while we're here, but really what we're really going to try to focus on is providing you with a certain knowledge set to sort of identify a behavioral or communicative style of yourself, and possibly to pick up some clues of what that sort of communicative or behavioral style might be with the person, patient, fellow colleague, husband, child, wife that you are trying to communicate with. Because not everybody communicates in the same sort of fashion. And sometimes there's breakdown in communication when you can't sort of have that person hear what you're trying to say. So we're just hoping at the end of all this, in the world of HIV, we are now going to be having patients that are going to be with us for a even longer period of time, because they're going to enter treatment earlier. The way the trends are going, they're going to enter treatment earlier. They're going to be with us for a long time. They're going to start treatment earlier. So we're really going to want to build some nice, long-lasting, trusting relationships with our patients. So from the get-go, we should probably figure out the best way to communicate with them and try to better that, because we want them to be free to talk with us about things like their HIV disclosure, their status, their treatment, their side effects. We want to be approachable, and so we want them to feel comfortable and calm, and that we are hearing them when they tell us these things. This program was created by a stellar faculty of family doctors, ID doctors, pharmacists, pretty representative of the country. We have some Western, Quebec, Ontario representation on this committee. I am Linda Robinson. I was the sort of lead consultant, project leader on this. I am a pharmacist by trade. I work at the HIV care program in Windsor, and I chair the Ontario HIV Network, and am the incoming chair for the Canadian HIV Pharmacy Network. So why would I do something like this? Because I like to create CE things in my spare time, and I like to learn new things. And this was a great opportunity for me to sort of expand my own horizons and improve my communication with my fellow colleagues, with people like yourselves, and with my patients. Well, I'd like to really applaud Janssen for kind of thinking outside of the box and not just giving us grants to have data-driven, product-driven educational pieces. It's hats off to a company that will actually give us some grants to come up with some good, fun, entertaining education. So I'd really like to thank Janssen for their role in this. And yeah. Yes, thank you very much. And if you want to hear more about it, or you want some of the kits that I'm going to show you at the end, or you want to refer this or have another workshop in your own center, you can always contact your Janssen representatives for that, but I'll allude to that again at the end. So what is the Buzz? If you are 25 years of age or younger, and you remember the Toy Story movies, or you are a parent of a child who watched the Toy Story movies, you will recognize that this is a Buzz. This is Buzz Lightyear. If you are even older, or you watch Dancing with the Stars, and you imagine the guy dancing with an astronaut suit on, this is also a Buzz. This is Buzz Aldrin. Anybody in this room who's very fortunate enough to be extremely techno-capable and is on their techno devices 24/7, which actually is an awful lot of people these days, you might be familiar with Google Buzz. But the Buzz program that we're going to talk about today is actually a communications workshop. And it wasn't just let's just get together and have a communications workshop. It was a stepwise approach to building a program that will be delivered to healthcare providers, that will be delivered to PHA groups, that will be shared with ASOs. It was based on some studies that were done that I'm going to show you really quickly where that information came from, because it's previously been presented. But it was a nice work in progress, and I think you'll appreciate it for the work that's gone into it. We started with a patient perspective. We've added some information from a study called Beehive, which I'll refresh your memories on a little bit. And then we learned some valid communication skills from a company called Solutions in Mind. Solutions in Mind is a company that actually helps people communicate. They work with big businesses, they work in big teams, they actually teach this whole method of communication. So we did have expertise in coming up with this information. So we did, like I said, we've created healthcare providers, ASO programs. There's currently an ASO program called Bridging the Gap that is running just down the hallway a little bit. And then, of course, it's a perfect model of KTE, or not the buzzword, not to coin a phrase, but KTE, or Knowledge Transfer Exchange. So it's meeting all the requirements of good, solid education. So this is what I want people to start thinking about. Before we go on, though, is anybody in the room did not get a survey to sort of fill out, to sort of find out what your style is? Raise your hand, and there's our lovely Anna will bring one to you. Okay, so I want you to think carefully about a couple of things here, and you can kind of read along with me in the slides. Have you ever had a patient who has had ongoing antiretroviral toxicities? Just think about these things. You've suggested that they try a variety of new options, but for some reason they're very reluctant to make any changes. Well, Janssen sponsored a study that interviewed a group of PHAs, and it basically the bottom line is we were asking them, what stops you from discussing things like side effects or issues with your treatments with your doctor? What are some of the things that prevent you to talk to them about that? And I mean, I could go into a lot of detail about all of these, but it was presented at previous CAHR meetings and at a symposium that we did a couple of years ago. But basically, these are the 5 barriers that were most identified by our patients. And the suck-it-up mentality is exactly that. Yeah, maybe I'm having side effects, but I have HIV and I have to take treatment, so I better just suck it up and not complain about it, okay? The skepticism thing is, maybe I'm a little bit leery of trying that new drug. I don't believe that new drug is going to help me, so why would I bother talking to somebody about it? Minimization. Our patients feel that we minimize things like side effects. We may say, you know what, it might cause you a little fuzzy in the head, but it happens to everybody and it's going to go away soon. Some people want to hear that. Other people feel like that's being minimized. The devil means, okay, I have this treatment, I know it causes this problem, but maybe if I try something new, the problem's only going to get worse. So I'll just stick with what I have and I won't bother asking anybody. And then confusion with resistance is exactly that. People think if they change medicines, they burn that drug, even though they're suppressed, even though there's no chance of resistance. They don't quite understand that concept. So those were identified. So think of this now. Have you ever had a patient who answered all of your questions, but you suspect that they're not quite giving you the full or the real story? I'm pretty sure everybody can nod to that. Only to discover later that the patient downplays the degree of bother of anything that's affecting their life right now. Well, the Beehive study, which was 1,000 patients matched questionnaires that looked at physicians, offered them a questionnaire, and the patient the questionnaire after the encounter with each other, asking things like, do you have these side effects? Did you express these side effects? Okay, I'm not going to go through all the data because this too was presented at CAHR 2010 by Marianne Harris in Saskatoon. But the bottom line was there was a good agreement in the recognition of symptoms. In other words, if a patient said, yes, I have some diarrhea, the doctor heard, yes, I have some diarrhea. Okay? But where the discrepancy lies is that if the patient may have answered their questionnaire saying, I really, really expressed to this doctor that I have diarrhea, and the doctor may have said, it didn't seem that bothersome that the patient has this. So there was a breakdown in communication somewhere in what they both reported they heard and said, but actually how it was perceived. So the bottom line was that it raises questions that we need further research to help optimize this communication. because you don't know where that breakdown happened. Did it happen because the patient may not have expressed just how bothersome something was, or did it actually happen that because the doctor did not hear it? So nobody would really know that. It was behind closed doors. So all the more reason why you maybe need to come up with a better way to help people communicate. So a companion program for the PHAs to sort of identify their style and recognize their physician's style and adapt, and maybe a program for the healthcare providers so that we recognize our style, we see some of our patients' styles, and then we learn to adapt. So consider this one. No matter how many times you describe something, you're left unconvinced that a patient actually heard anything you said. Everybody's grinning because I know people can relate to these things. Or a patient where it's difficult to act, you feel like you're grasping at straws. You can't really get to the bottom of things. It takes a lot of time and a lot of effort. It's not just natural that you can get information from them. Or a patient where you're not certain just how much you need to give them information because they might just shut down after part A and forget D, C, E, okay? The reason why you feel that with some patients and not others, and I keep using the word patients, but please remember it could be colleagues, it could be your spouse, it could be your kids, all right? So sometimes you feel that you really make a connection with some people, and then other people, you just, no matter what you do, you feel like you're bashing your head against the wall because they're just not getting through. Well, chances are it's because your style with the person that just gets you is probably similar. But the person who you're not getting through, they're just not hearing your language. It would be like right now, for my French compadres in the room, I cannot speak French very well at all. Right? So if I stood up here and spoke just strictly English, as I am right now, to someone who is just Francophone, they wouldn't really hear what I have to say. But again, if I tried to adapt that and maybe pick up a few little French words here and there, because I understand that person listening actually needs to hear it in that language, then they might pick up a few of my clues and be more likely to hear what I have to say. So it's the same thing with your communication style. If you are a very chatty, outgoing, energetic person and you sit down with someone who's also very chatty and outgoing and energetic, you're going to have a great old time and have no problem talking to each other. But if you have a person who's like, whoa, like that person's coming on a bit too strong, you may have to recognize that and then actually go to a different realm and try your hardest to pull back a bit and adapt their style more so that they don't feel as confronted and they understand your language better. Okay? So, based on that, the Solutions in Mind folks shared with us a very complicated program called the DISC method. And the DISC method is a very intensive, relevant, proven method that is very onerous to take on, and it involves a survey that is very long and difficult to take. So we tried our best to take the information from the DISC program and simplify it as best we can so that we can quick and effectively use these sort of skills with our patients. What it is not is a measure of anyone's intelligence. It does not indicate anybody's values. It does not measure anybody's experience, and it is not a measure of anybody's education or anybody's training. It is simply just a measure of how a person behaves, and more so of how a person communicates. It's how we act, we behave, and it's a neutral language. There's no right or wrong. It's just your style. And everybody's style is just their style, okay? So, to break things down a little simpler, what we did is we tried to define the DISC. So, in a nutshell, and keep in mind the color wheel, because I'm going to bring this back to behavioral colors, which you are now all wondering why you're filling out those forms and what is this telling you. We're going to really now take it from something difficult and bring it down to something useful and effective in the clinics. So, a D, or more of a red persona, tends to be a very driver-dominant personality. An I, or the more yellow-orangey, tends to go more towards somebody who can influence others and promote things because they're very extroverted and outgoing. A green, the S, is supporter or a steady. And then the C, it would be more of a compliant, analytical type of person. So again, the DISC, it can be simplified even further. But before we do that, let's wonder what happens if a red or a D goes all the way to the extreme. What they can be is somebody who's a bit bossy, directs a little bit too much. Okay? A yellow can be somebody who's a little too chatty and talks way too much. That's that person that sits in your office and they tell you all about their life and they tell you all about their trips and they go on and on and on about this, that, and everything else. And maybe in the last 5 minutes of your encounter with them, they actually get down and dirty and tell you what you really need to pull from them. Now, if you're another yellow, that's great. You kick your feet back and you have a great little chat. And it's not the best use of your time. I can vouch for that. But you develop a really good rapport with that. But if you're on a strict schedule and you're oriented to stay on task, that can be a very frustrating experience if somebody's chatting a bit too much. An S, or to the extreme, agrees a little bit too much. They want to please. So they agree with almost everything you say and may be hesitant to bring up other things. And a C, on the overextension, or a blue, actually kind of sometimes asks too many questions and may confuse the issue by too many questions. If you want the best one-on-one encounter, they say it is best to work with someone in your own quadrant or your own color. But imagine, and we were given this example by Steve, the Director of Solutions in mind, if you had a boardroom that had a project to do and really needed to get the job done. If you had a room full of yellows or I people, they would be a great, fun, energetic room, but at the end of the day, the project probably wouldn't get a whole lot accomplished. So the best group is actually a clinic staff or a work environment is best if people can actually be pulled from all different colors, all right? Or if people are trained to adapt their color. Now, I'm going to tell you right now that I am, when we get to the next thing, I'm going to tell you that what my color style has been identified as. I'm sure some of you can guess who know me. Kara's laughing. But there's no cut and dry. It depends on the context, and it depends on the situation that you are in and the relationship that you are in. You may not always be using a red if you are naturally red, because that might overpower your partner who is a green. So we have to adapt, but we also display all of these colors at any given time. It's just there are surveys that can tell you what sort of your more predominant or your most comfortable style is, and that's what we're trying to do here. So we've broken it into little quadrants. And if you filled out the survey, you'll see this same sort of color quadrant on the back of the survey. So just to break things down a little bit, a blue persona is said to be more analytical, contemplative, exacting, conservative, careful, and deliberate. So if you filled out a survey and you came into the blue quadrant, think to yourself quietly right now if you think that is you. A red is very ambitious, forceful, decisive, direct, independent, and has no problem challenging people. A yellow is very expressive, very enthusiastic, very friendly, uses their hands a lot when they talk. They're a very stimulating person to have a conversation with. And a green is more methodical, systematic, reliable, steady, relaxed, and fairly modest. So those are the traits that go along with those colors, in case you are wondering. Now, if anybody has filled out the survey, at the end of this, you can come up to the front, and we have green, red, yellow, blue pages that outline all of those traits for you to take home if you want to know about yourself. Okay? Let's take it even a bit simpler, though. Okay? If you were to draw a line down the very center of the quadrant, the blues and the greens tend to be a little more introverted, introspective, and the reds and the yellows tend to be a little more extroverted. Okay? I am an orange. I fall very, very close between the red and the yellow. And I think the reason for that is that if I'm in a situation where I'm social, I'm very much a yellow. But if I'm dealing with a project that needs to be accomplished, or I'm dealing with corporate personnel, I'm very much a red. So I'm using my extroversion but I'm using it in different contexts, in different encounters. So it's probably more comfortable for me to be yellow, which is why when I fill out the brief survey, I'm just straight yellow. But I can see extroversion and traits of red in myself because I've had to learn that in certain context. Okay, so you understand you have a stronger one that you're the most comfortable with. I'm the most comfortable speaking English, but I have had to learn a few phrases in French because of my French patients. All right? So it's the same thing. I'm more comfortable communicating yellow, but I've had to learn to maybe not every environment's going to want me to be in their face and chatty and laughing and all that. Okay? So that's just that. Now let's look a little bit further. If you were to draw a line across the center, now you have task-oriented more in the blues and the reds, and people-oriented more in the greens and the yellows. So a red is an extrovert who's task-oriented, ambitious, forceful, challenging, gets the job done. A blue would be considered more introverted, task-oriented, analytical, wants to dot the I's and cross all the T's. Great person to have for clinical trial work because they're very analytical, methodical, they're systematic, they don't let the boat rock them too much, but they're on task. A green is a people-oriented but somewhat shy introvert. So it might be that patient who wants you to think everything they're doing is just right. And please give me the pat on the back because I'm doing my very best to follow what you're telling me. Okay? If they're people-oriented, they want to look you in the eye, they want to have that friendly conversation, but they're more pleaser versus in your face. Okay? And a yellow, not necessarily that they're in your face, but a yellow is an extrovert who's chatty. So chatty Cathys, okay? So now just take a minute out, and when I call this out, I want people to raise their hand and keep their hands up, okay? So if you filled out a survey, raise your hand if you came up as red. Okay, keep your hands up. Raise your hand if you came up as blue. Keep your hands up too. If you came up as yellow. And if you came up as green. So every single color that I called out, you guys can't see yourselves as well as I can, but every single color that I called out, I would say almost an equal proportion of hands went up. So in this room alone, we've already identified a fair number of people who communicate very differently from each other. So if there's that much diversity in such a small group of healthcare professionals, there's certainly going to be that much diversity in your 500 patients that are coming to your clinic, okay, or your ASO. So once you learn what someone's communication style is, you learn some little traits on how is best to communicate with a red. So a red is that person who wants to get the job done. You know, they're extroverted, they're outgoing, so they probably would respond best to someone who's going to keep their distance, but they're going to have a real strong, a firm handshake with them. They're going to look them right in the eye. They're going to lean forward, controlled gestures. They're going to use things like, you know, this is new, this is improved, we're going to win at this, you can do this. They're going to respond to things like that. Strong, confident, clear, loud, and direct, not necessarily instruction, but communication. All right? So that's a red communicating with a red. If you are naturally red, you are going to have no problem talking with people like that because those people you're naturally going to communicate that way. However, I'm going to skip 2 slides ahead because I want to prove a point. Imagine if you used what I just showed you with how a green thinks. To best communicate with a green, you need to be more relaxed. You need to make small gestures and use eye contact, but not direct, assertive eye contact. You need to use warm, soft, steady, low volume messages. You need to use words like, this is step by step, we're going to get through this. How about you help me out to help you decide what's best for you? But you give me a clue, because I want to be proud with you when you accomplish this. This is what speaks to greens, right? I promise you, if we work together on this, we can beat this. Greens can hear that kind of language. I have to subdue myself to be like that. I really do. I do it. I can do it. Obviously, I just did. But I have to subdue myself to be like that. I'm much more like, let's take this on together. We can do this. Let's beat this. Are you with me? So I have to be careful that my introverted, people-oriented person doesn't feel too overwhelmed by my extroverted, people-oriented style. Okay? So again, a red would naturally come very forceful. And in an encounter like that, it may completely intimidate that person. I want you to think about this. Imagine you are a yellow, very chatty person, just yourselves, okay? And you're going to your own healthcare provider. So you go in there and you want to have a chat. And you want to tell them that your son is in university now. You want to tell them that you just took a trip with your family. You want to talk about your medical things, but you want to have a little chat with your doctor, right? And you're sitting there because you're this yellow, so you want the person to look at you. You want the person to engage. And your doctor sits there with their head down or looking at a computer screen and starts going, okay, last time you were here, we did this. Have you been taking that? Good. Last time we were here, we did this. I see you got your labs done. So they're very task-oriented, non-eye contact, right? If you were that outgoing person going to your own healthcare provider, how would you feel about sharing some intimate personal things with that person? Because that person's not giving you the time of day. In your world, it seems like they're not giving you the time of day. And it's not the doctor's fault. They're just not, that's their style. They would do very well with someone who came in with a list of things and wanted to write down all their labs and wanted to show them all their things, because that doctor would be task-oriented, that patient would be task-oriented, they'd both be a little more introverted, so they'd get along just great. So I want you to go back quickly, because what I've found in doing these workshops over and over a few times is I think there are times when both task-oriented personnel would do well together. So I think a red sort of president taking over things would do very well with a personal assistant that helps them stay on task, because the red appreciates task but is really out there and may need some help staying on task. Okay? I think the people-oriented people may get along better. As long as the extroverted yellow isn't too much in someone's face, I think the green would respond okay to them. So you just got to kind of simmer it down a tiny bit. Where I think the biggest discrepancies lie are when you're sort of on a diagonal. If I had another slide chance right now, I would make that third slide and draw a line through the diagonal. Because I think those are the ones that are completely opposite spectrum that are going to be the most difficult. So even if you go back to your practices and you think of patient ABC that, you know what, I have never been able to get through to that person. And even if you just learn very quickly and try to summarize what that patient A, B, and C's color code is and find out it's very different than your own, and you only have that with those three patients, you've already started building a better communication system with your staff. And it's something that, your patients. And it's something that if you keep practicing it, you get better and better at it. Some people are naturally capable of adapting. Naturally capable of it. And it's a gift. I think it's an adaptation that can happen when you're in a particular relationship, long-term, ongoing, which is why I feel like I have a much better rapport with my patients that I've had for 14 years now, because after all this time, we certainly have figured out each other's styles, and most often we communicate fairly well. In my own partnership, will often end up with somebody completely opposite the spectrum of us in personal relationships, because that person is the yin to our yang. That person provides the balance that we don't have. So sometimes you end up in learning to become more, for example, my husband is definitely more of a green-blue, and I am definitely more of a red-yellow, hands down. And we've been married 28 years, and he has learned to adapt to my style, or put up with my style, maybe I should say. And I have learned to simmer it down sometimes when we need to work on something together. And since I've done this workshop, I actually see myself going in full barrels, and I see the resistance in my husband and in one of my kids. I have 2 other kids that are exact same that I am, I think, or not exactly the same, but sort of fall in the same area that I am. And I'll give you an example right now. My daughter, 16 years old, falls in the exact same category as me. She's been texting me this morning. She texted me right before this talk, and she said, "Good luck on your talk, Mom. You're going to knock them dead." This is the red-yellow daughter of mine. And she said, so put on how did she say it? Put on those red pants and spank it. That's what her text message said. So I texted her back, and I said, and she's a performer, so she knows when you have to buckle down and force yourself, and then when you have to be the sort of extrovert. So I texted her back, and I said, "It's funny you say that. I got my red pants on right now because I got to get this done. I'm going through my slides as we speak, as we text. I really want to knock this out of the park. But I think I'm going to put my yellow pants on so that the crowd actually really likes me, and I'm really bubbly and really friendly." So she texted me back the same thing, and she goes, "Kind of like when I do a performance." So it's so easy for us to communicate because we're both similar that way, right? If I texted my other daughter and told her I was doing this talk, she'd be like, "Well, I know you're going to do great, Mom. Did you get your slides all set? Have you gone through them? Because she's much more that analytical, methodical kind of kid. And it's funny how you learn how to use these skills, like I tried to say earlier, not just with your patients. You learn them with your colleagues, especially your coworkers. Because if you have a staff of multicolored staff, and in our own practice, we have patients that will particularly want to speak with one of us over the other team. And when you look at that, it's not because they don't like the rest of the team. It's that their color is almost exactly the same as the one of us that they tend to get the message through to. Right? We have 2 doctors in our clinic, and sometimes a patient will actually request a change in physician. And our doctors don't get all bent out of shape about that. We try to adapt and be the best we can for any of our patients, right? But and you can see over time, I have doctors that are different, very different. And the patients that have made the switches, now I totally understand why they feel more comfortable switching to that other doctor. Right? So these are skills that you can use in a lot of different arenas. Does anybody have time? Sorry. How am I doing for time? Okay, good. You know what, Natalie, just give me like this when I got like 10 minutes left. Okay? I'm actually on task. We're doing okay. I'm on task. I'm red right now. Okay, so to communicate with a red, let's just kind of reiterate that a bit. You're best to learn to keep your distance, but be direct, eye contact, sort of remember that person wants to get the job done. So it's okay for you to have that go team, go, get the job done in their face a little bit with that person. Okay? As long as you line up what they need to do to get the job done, because they're the task-minded person. Okay? For these patients, they're sometimes very, very challenging. You do want to sit and chat with all of them. But in a busy clinic and on a busy doctor schedule, how many physicians in this audience would find if every single patient came in and wanted to talk with you for 20 minutes, you'd never get the day done. So there's some things that you can do with these. Maybe acknowledge them right from the beginning. One of the suggestions that our advisor said was maybe this is the type of person that you meet them sort of in the waiting room, and as you're walking to the exam room, you keep yellow and you keep chatty and you find out all the stuff you need to find out from them. But then once you get into the exam room, you sort of rein them in a little bit and get them on task. You've already acknowledged their chatty style, so they feel open up a little bit now. But then you can still bring them back in. But if you just sit in your office or walk into an exam room with your head down on your chart, reading the results, and not even make eye contact with that person at all, they're probably not. They're going to feel very shunned because they're very friendly, outgoing people. Okay? So remember that. Keep that in mind. It's sometimes not easy to do, but sometimes little tiny differences will make it all much better. So communicating with a green. Remember, this is the patient who wants you to be proud of what they're doing. They are pleasers. So they want you to say, you know what, because you have taken those meds daily, faithfully, look at your results. You should be so proud of yourself, right? They want that. They don't want the good job, got your lab done. They're not task-oriented. They're people-oriented, but shyer, so to speak. So, again, using soft tones with them, speaking down more at their level, not being too confrontational, but realizing they do want to talk because they're friendly, outgoing, and they want you to be happy with them. A lot of us have kids like that. That you just know some kids thrive on you patting them on the back, and other kids thrive with you. They're like, what are you telling me that for? Right? So, and same with our relationships. Now, same with a blue. A blue, remember, is introverted. A blue doesn't want you to be overly friendly and huggy and warm and cuddly with that person. So if you're a hugger and that blue patient has come in and they've got their book and they've got their studies that they've looked at about the latest switches in medicines, and they want to have a chat about that, and you walk up to them and give them a great big warm hug and say, how's the family? They might be like, like some people don't like physical contact. It's okay. Like, you're a hugger or you're not a hugger. It's not, one's not right, one's not wrong. It's just that you have to kind of be aware that some people may not appreciate that approach. However, if you've got a yellow, they probably would love a great big bear hug every time they come into your clinic, right? Because they're that person who likes that warm, friendly embrace. So if we're going to summarize this whole DISC concept, by no means are any of us to leave here thinking, oh, it's this piece of cake. All I got to do is put someone in a quadrant. Dr. Marie-José's looking at me going, you got that right, Linda. I'm a psychiatrist in the crowd. We're not saying that you just put somebody and pigeonhole them into a quadrant and therefore your life is going to be much easier. By no means. It's one, if you were to think of communication as a big fat onion, all we're barely doing is peeling off the first layer by learning things like this. But a skill like this is something that's quick and easy. You can try it on with your relationships and see how it works. So we really think that you can improve communication just by knowing what your own style is first and foremost. Then kind of try to identify, it's like a game, try to identify what someone else's style is. And then adapting that communication to different behavioral styles, learning how to adapt so that you can reach out to somebody else. That's the harder part, but it can be done. And I think that will really empower healthcare providers and patients to come together a little better. And like I said earlier, with the way the guidelines are going, we are going to be taking them in earlier, we're going to be treating them earlier, and they're going to live big, long lives. You've heard that repeated over and over again at this conference and everything in the last couple of years. So it's like a marriage. Are you going to go in and for 28, 30 years, or however long we're all going to stay in this, and have butt heads every time that person comes in? It's going to make everyone's life easier if you kind of learn to have a good relationship, because then they will feel comfortable with you. They will tell you their issues, and you will be able to get them to that 35, 40 years of longevity and have a quality of life that is most important. I think we have to keep in mind, I do a lot of talks, and I'm often speaking about goals of therapy because I'm a pharmacist, so I do a lot of talks on drug treatment for HIV. And we have the outlined goals of therapy in the DHHS guidelines. And number one goal is complete and durable potent viral suppression. Everybody would agree with that, right? The number two is a goal of therapy is immune restoration. So improvement of the immune function, a rise in CD4 count. It's not completely successful therapy if you don't see one go down and the other one go up. The one part of the goals of therapy that's been in the list since I remember first reading the DHHS guidelines, which is about 15 years ago now, it's always in that list, it's never been taken off the list, is to improve the quality of life. Because if someone doesn't feel that your interventions are making their life better, they're less likely to buy into your interventions. If somebody doesn't feel like you are just an assistant, a healthcare provider who is trying to motivate them to see what the best choices for them are in order to have some quality in their life, you're not doing them the healthcare service that you should be. Because as healthcare providers, we know this, therefore you should do this. We have some information that you might be willing to learn from us, because I think we can help you along the way in making the right choices so that your life is quality. So at the end of the day, it's not about the textbook stuff that we know. It's about how we get people to actually hear what we say, what we want to say. And this is only just going to start us getting on better at that. Okay? Now, for this, all sakes and purposes, we do have a complete workshop that goes with this. But in this environment, and we did have to kind of tailor it a little bit different when we found out it was in this great big room. We're not actually going to sit down a round table discussion and do some of the cases. But I can stand here and describe to you one of the cases, and then we can, as a show of hands, kind of get an idea if everybody gets what that person's predominant color is. But for the record, there are 4 identified cases that go with this workshop that not only talk to you about a person's style that you are to identify, but they also ask the group to come up with role-playing ways to try to communicate with that person. It's a lot of fun. It can be done in your centers, in your ASOs, in your clinics. All you have to do is contact your Janssen rep, and I'm sure they'd be glad to set something like that up. But for the sake of this our audience, I will just sort of describe a person, and then we will ask everybody by a show of hands what that person's style is, okay? So I'm going to introduce you to a fella. This person has been HIV positive for the last 14 years. They are on their 3rd regimen, and they are sitting across from your desk. And they are now hyperlipidemic. They have high cholesterol, and they're getting a little bit older. And the doctor today wants to talk to them about their cardiac risk and whether or not they can do something to try to change that. So he's sitting across from your desk, and you start to mention what the lab results are and where we're going with this. And immediately he says to you, "Well, doctor, I've been living with this disease for an awful long time, and I'm pretty sure I understand what my risks are. And as a matter of fact, I know you're going to tell me again that I should quit smoking, and I've told you before I have no thought whatsoever about quitting smoking. It's the only vice that I have, and I'm going to stick with it. If anything, I would like you to take a look at my antiretroviral pills and tell me whether or not you think there's anything I can do with that, because one of my friends is only taking this regimen." So just telling you that alone. Who thinks that person is yellow? Blue? Red? Bingo. Certainly not green. Okay? The green guy probably would have said, I know I probably should start really thinking about these things. So, I want to do whatever you tell me I need to do. So I really don't want to quit smoking, but maybe I should, because if you say I should, I probably should think about it, right? Persons who don't want to quit smoking and do it because we think they should are never going to quit smoking, right? So that's how a green would have responded, right? A red, he was confrontational. What made him different from being a yellow was that he didn't go in there and sort of just say, "Oh, yeah, we're going to talk about the smoking thing again. I get it, but guess what? I don't want to do it. Guess what I did last weekend?" Right? But he's not going to be like, "I don't want to do this, therefore, but I do want to do this." That's the difference, the subtle difference. He's task-oriented, right? He wants to confront you with what he's going to do, but he wants to go through a task list of it. Versus the extrovert who will, I'll confront you in a friendly way, but I'm more interested in what you're going to tell me. 10 minutes. Okay, perfect. So on that note, and I'm going to give you guys 5 minutes extra so that you can actually get to the next abstract session, because the schedule gives us 0 seconds to get from one thing to another. But I want you to be aware that that case that I just went through with you is similar to one that's in the program. So I would really like to encourage you, if you're interested in this, it's a fun workshop, and I'd like to encourage you to get your reps to come out and do it with your group, because not only is it going to reiterate some of the stuff I've done today, so you kind of get a better handle and you practice a little bit more with it, but it's also going to prepare you for something that we have coming down the pipe. So the key takeaways from today are going to be that I think we've identified that there are a number of barriers that may prevent good, constructive, result-driven communication between the healthcare providers and their patients. Okay? I think the barriers are not only there, but sometimes they inhibit us from actually communicating to even the depth that we need to, so that we both hear what the other person is saying properly. Okay? And I also think, though, that this workshop has provided us with some very premature peeling back the first layer of the onion skills that'll help us sort of identify our own style, and then therefore be able to adapt and identify someone else's style and adapt our style to that person. If you haven't had an opportunity to fill out one of the little questionnaires that sort of tell you where you fit in, there's some up at the front here. You'll also be able to find some at both the Janssen booth and more so the booth in the far corner from Katie. They have the questionnaires at that booth as well. So if you want to go and even get a few maybe to bring back to your practice and see where people sit, and then maybe encourage some visits and some interaction with your group, that would be a great thing too. We do have 50, for the first 50 lucky people, a takeaway gift. There is a kit that goes with you that is a set of cards that you can actually, I have it stuck up on my bulletin board. And I am a very busy, specialized clinician. I just treat the HIV patients as the clinical pharmacy specialist in my practice. And I get reams of information come from drug companies. And some of the stuff that I know now that I've worked on these CEs, I know the work that goes into putting these things together. And it's a long process and a lot of work. But some of them, and any clinician who's in this room can say, you know what, it ended up on my desk, and when I cleaned out my office a year later, it went in the recycle bin. We're saying things like this might be something that you could just stick up and refer to on a regular basis. It gives you the 4 quadrants. It gives you the task-oriented versus people-oriented, but it also gives you the different ways you can communicate with that color once you've kind of identified what someone is. So it's a really nice little cheat sheet, and Steve and Judy are going to hand those out to you right now. So you can take those back to your practices, give them a go, try it on with some of your colleagues, some of your patients, some of your own associates, your kids, your spouse, and see how good you are at it. And then try it on a few patients, because when we get together for another program, which I'm not sure, oh, here it comes up. We have a Buzz 2. Coming soon to a theater near us. We have a Buzz 2 that's very close to coming to fruition, and it's going to provide us information on identifying motivational triggers. So it's kind of like peeling another layer of the onion. So we're hoping that if people get excited about learning this initial Buzz 1 program, that they'll be excited now to go even a little bit further for that patient they're still having a difficult time with. Maybe they're not motivating them the right way. And there's different things that motivate different people. So we're hoping that this will generate interest in Buzz 2, and I just was involved in the completion of Buzz 2, and it's a very exciting program. So thank you all for coming. I'm glad that it's a great big room for a kind of a personal talk. I feel very impersonal up here, but I've seen a lot of acknowledgement, and I really appreciate people who nod when I'm talking, because it makes me feel like I'm not just talking to dead air. Thank you all for coming. I hope you enjoyed it, and by all means, if you want to share it with your colleagues, just contact the Janssen and we'll get it to you. Thanks. I suppose if there's actual questions, that if anybody wants to get at the mic and actually ask a distinct question, we probably have a couple of minutes for some questions. But if not, just talk amongst yourself and find out the guy beside you what color he was and see if they agree with it. Thanks, everyone.